focusing on GLP-1s, which is, the big deal these days that everyone is worried about and anxious about, the biggest highlight for me, the key thing, do not stop the drugs, because we're all focused and fixated on what's going to happen at induction of anesthesia, intraoperatively, postoperatively, because of these drugs, but we're not thinking about what the risks are of stopping them. And we've got to think of balancing those risks of continuing versus stopping. And if you want to stop the drug, you need to have it stopped for at least a month in general, which is not really pragmatic, not practical. And then the impact to a patient's BMI or their glycemic control in that time will be significant. So what we're saying is, pragmatically speaking, do not stop these drugs. Risk assess each patient. So you've got to think of the patient risks, the surgical risks, and the comorbidities. So we know that someone who's taking a GLP-1 receptor agonist, by definition, has at least 2 risk factors for delayed gastric emptying. So obesity or diabetes, independent risk factors, and the drug, independent risk factor. But if we're thinking of all the other risk factors, we need to try and account for that. So risk assessment, share decision-making with the patient. Most patients are really clued up about this now, have a conversation with them, tell them, these are my concerns. These are the things I'm worried about. If you can do gastric ultrasound, then do that, because that helps risk stratify that patient. We don't think you should be changing fasting guidelines just yet, but that is work that's ongoing. Let's be honest, we have to view these drugs as one of the many risk factors for delayed gastric emptying. So let's not panic, continue the drug, risk assess the patient, share decision making. And if you can do a block, do a block. If you can do gastric ultrasound, do gastric ultrasound.